Chapter 19 Trauma and Stress Related Disorders. Post trauma response has been known throughout history by various names. Some include shell shock, battle fatigue, accident neurosis, post traumatic neurosis. And the DSM-3 was the first edition that had the diagnosis of post traumatic stress disorder or PTSD. So if you recall, that's the manual with the criteria to diagnose mental illness. And we are currently on book edition 5. So traumatic events are described as one that is outside of the usual human experience, and PTSD or post traumatic stress disorder is more common in women than in men. Less than 10% of trauma victims develop PTSD. So, adjustment disorder, I want you to know what this is. So, adjustment disorder is more common in women, single people, as well as younger people. Adjustment disorder is a psychological response to identifiable stress or stressor, and this is normally more of a usual event, and the person is having a problem adjusting to this common stressor. PTSD, or post traumatic stress disorder, is a reaction to an extreme trauma. It is marked by distress in most people. This trauma can occur alone, or you can be in the presence of other people. So, this could be a terroristic act, it could be rape, it could be a murder, it could be a man made disaster. So, characteristics of PTSD. So, what I want you to know is there is a high level of anxiety as they re experience these events when they think about the events. So they have intrusive recollections or nightmares about the event. And when they occur, the level of anxiety as if it was occurring for the first time, right? Some individuals may be unable to remember certain aspects of the trauma. So they may have amnesia, they may have depression or survivor guilt, they may have substance abuse, anger, aggression, relationships. So I'm not going to read every bullet to you, but I do want you to know that the level of anxiety does not decrease with this PTSD. It's almost as if they just experienced it for the first time. PTSD symptoms last longer than 1 month, but they can occur anytime up to 3 months after the trauma, and sometimes it can take months or even years after the trauma for these symptoms to develop. But the symptoms must last for at least 1 month and impact their social and occupational functioning. So the person is experiencing or re experiencing the event as they recall the event as if it just happened, and the level of anxiety is high as if it's just happening and they have seen it for the first time. I want you to know what acute stress disorder is, ASD. So the symptoms for acute stress disorder does not last longer than a month. So the symptoms are limited up to 1 month post the trauma. If it goes longer than 1 month, then it's diagnosed with PTSD. Predisposing factors. So, psychosocial theory seeks to explain why individuals are exposed to massive trauma develop PTSD while others do not. Variables include characteristics that relate to the traumatic experience, the individual, and the recovery environment. Learning theorists view negative reinforcement as behavior that leads to a reduction in the aversive experience. So, avoidance behavior may occur, psychic numbing may occur as well in response to the trauma. And psychic numbing is the inability to express love, closeness, or emotional expression. And we have our cognitive theory. So, the cognitive theory model focuses on the cognitive appraisal of an event and the assumption that an individual makes about the world. So, we have our biological theory, which suggests that symptoms related to trauma are maintained by the production of endogenous opioid peptides that are produced in the face of arousal or which result in increased feelings of comfort and control. When stressors terminate, the individual may experience opioid withdrawal and symptoms of which bear a strong resemblance to those of PTSD. Other biological symptoms that have been implicated in PTSD: norepinephrine, dopamine, and benzodiazepine receptors are some of the neurotransmitters believed to dysregulate in an individual with PTSD. Trauma informed care is a strength based framework that is grounded in the understanding of and the responsiveness to the impact of trauma, that emphasizes physical, psychological, emotional safety of both the provider and the survivor, and it builds a sense of control and empowerment. Please refer to your textbook, Table 19-2. The next few slides will go through the nursing process. We're beginning with nursing diagnosis. So I have post trauma syndrome, which is the same as PTSD, and it is related to distressing events considered to be outside of the usual human experience, resulting in flashbacks, recollections, nightmares, psychological numbing, amnesia, disassociation. Then we have our complicated grieving related to loss of self as perceived before the trauma or other actual or perceived loss occurring during or after the event. So our outcome criteria. So this is what we want to occur for our patient, right? So we want them to be able to acknowledge the trauma and the impact it's had on their life. We want them to be able to adjust and develop some coping strategies, right? Set realistic goals for their future, work through their feelings, attend support groups, um, be able to verbalize their desire to put the trauma in the past and to progress with life. Planning implementation. So, nursing care of the client with traumatic related disorder is aimed at reassurance of safety, decrease in maladaptive symptoms, demonstration of more adaptive coping strategies, adaptive progression throughout the grieving process. So, evaluation of care for your client with traumatic related disorder is based on successful achievement of the previous established outcome criteria. So, can your client discuss traumatic events without experiencing a panic attack, right? Or panic anxiety? Has the client learned new adaptive coping strategies to assist them with their recovery? Okay, I would like you to know what adjustment disorder is. Adjustment disorder is characterized by a maladaptive reaction to identifiable stress or stressor that results in developmental, clinical, significant behavioral and emotional responses. So this response occurs within 3 months and lasts no longer than 6 months. So the person is experiencing a social and occupational malfunction or impairment. Adjustment disorder. So we'll go through each bullet. So, adjustment disorder with depressed mood. The individual experiences a mood disturbance. This mood disturbance consists of tearfulness, feelings of hopelessness, depressed mood, and it exceeds what is expected or normal for the identified stressor. So, adjustment disorder with anxiety is a maladaptive response to a stressor in which the predominant manifestation is anxiety. Then we have our adjustment disorder with mixed anxiety and depression or depressed mood. And this is a disturbance in mood and manifestation of anxiety that is more intense than what would be expected or considered normal for the identified stressor. Then we have adjustment disorder with disturbance in conduct, and this is characterized by conduct which is violation of rights of others or majority or major age appropriate social norms. So then we also have adjustment disorder with mixed disturbances of emotions and conduct. So this presents as emotional as well as a conduct disturbance in which the rights of others may be violated or major age appropriate societal norms may be violated. Next, we have so that one is the same as conduct with the exception that emotional is an emotional response as well as a conduct response. Then we have adjustment disorder unspecified. So the individual may have physical complaints, withdraw from relationships, or exhibit impaired work or academic performance, but without significant disturbances in emotions or conduct. Predisposing factors, so the biological aspect. So chronic disorders such as neurocognitive or intellectual development disorders are thought to impair the ability of an individual to adapt to stress, causing increased vulnerability to adjustment disorders. And also genetic factors may influence an individual's risk of maladaptive response to stress. Psychosocial theories. So some psychoanalysts view adjustment disorder as a maladaptive response to stress that is caused by early childhood trauma, which increased dependency and retarded ego development. Then some psychoanalysts put more weight on constitutional factors such as birth characteristics that contribute to how a person deals with deals with stress, while other studies demonstrate that developmental stage, timing of the stressor, available support system has everything to do with how a person handles stress. So that has to do with the developmental maturity of a person. Transactional model of stress adaptation. So this model takes in consideration the interaction between the individual and the environment. So we're talking about the type of stressor, the situational factors, as well as their interpersonal factors. The next few slides will go through the nursing process for adjustment disorder and refer to table 19-2. Nursing diagnoses include complicated grieving. So complicated grieving related to real or perceived loss of any concept of value to the individual, evidenced by interference with life functioning and developmental regression or somatic complaints. Next, we have risks for prone health behavior. which is related to changes in health status requiring modifications in lifestyle. This is evidenced by an ability to problem solve or set realistic goals for the future. Note the diagnosis must be appropriate for the person's age. Then we have anxiety. So this is moderate to severe anxiety, and it is related to situational or maturational crisis. Evidenced by restlessness, increased hopelessness, decreased productivity. Outcome criteria for adjustment disorder. So this is what we want to see in our client. So the client should be able to verbalize acceptable behaviors associated with each stage of grieving process, demonstrate reinvestment in their environment, accomplish their activities of daily living independently, demonstrate ability for adequate occupational and social functioning, verbalize awareness of changes in health status and the effects it has on their lifestyle, involve problems and set realistic goals for the future, demonstrate ability to cope effectively with change in lifestyle. Planning and implementation. Nursing interventions for the client with adjustment disorder is aimed at adaptive progression through the grieving process, helping the client to achieve acceptance of a change in their health status, assisting with strategies to maintain anxiety at a manageable level. So, evaluation is based on accomplishments of the previous established outcome criteria. So, we're evaluating if the things we implemented achieved our outcome, right? So, is the patient progressing through the grief process? Is the patient making modifications or adjustments to their lifestyle to encompass their health changes? Is the patient able to identify realistic goals for their future? Treatment modalities for trauma related disorders. So, therapy strives to help individuals recognize and modify their trauma related thoughts and beliefs. Prolonged exposure therapy, or PE, is a type of behavioral therapy somewhat similar to implosive therapy or flooding. It can be conducted in an imagined or real situation. Then you have group therapy, which we encourage for our PTSD. It has been proven for military staff to work. Then we have our eye movement desensitization and reprocessing, or EMDR. It is a type of psychotherapy that involves movement of the eyes and causes decreased imagery vividness and distress, as well as an increase in access to their memory. And for our psychopharmacological, we have several different types of drugs that may be used for these patients. So we have our SSRIs, or selective serotonin reuptake inhibitors. This is our first line of treatment for our PTSD patients. We have tricyclic antidepressants. We have MAOI inhibitors. We also have our benzodiazepine, and we have beta blockers. And you can refer to your textbook in regards to the specific medications under each of these categories. Again, we're not heavy on the medications for our particular test. Treatment modalities continued. Individual psychotherapy is the most common treatment for adjustment disorder. Individual psychotherapy allows the client to examine the stressor that is causing the problem, possibly aligning personal meaning to the stressor and confronting unresolved issues. In family therapy, the focus of treatment is shifted from individual to the system of relationships in the individual's life. Then you have your behavioral therapy. And behavioral therapy is to replace ineffective response patterns with more adaptive ones. Then we have our group therapy or self-help groups, as mentioned on the slide. So this is either with or without a professional facilitator. And the goal is for members to realize that they are not alone in this painful experience. And members are considered and compare their responses to the individuals with similar life experiences. Then we have our crisis intervention. So the therapist or intervener becomes a part of the individual's life situation. Because of increased anxiety, the individual with adjustment disorder is unable to problem solve, so he or she requires guidance and support from someone outside of the situation. And we already discussed our psychopharmacological interventions on the prior slide. So we have ourselves a question. 2 months ago, Miss T was sexually assaulted while jogging in an isolated park. She is hospitalized for suicide ideation at this time. She awakens in the middle of the night screaming about having nightmares of the incident. Which of the following is the most appropriate initial nursing intervention? A. Call a doctor to report the incident. B. Stay with Miss T until the anxiety has subsided. C. Administer PRN alprazolam. D. Allow her some privacy to work through the emotions. I'll give you a second. And you're correct. The answer is B. So, sitting with a client, showing that you care, that they can trust you to help calm them and reassure them of their safety is the best intervention, immediate intervention. So, we have ourselves a question. Which of the following medication is considered to be a first line medication of choice in the treatment of PTSD? So, first we have our alprazolam, that's A, which is a benzodiazepine and is good for anxiety or anti anxiety medication. We have propranolol, which is a beta blocker drug. We have carbamazepine, which is an anticonvulsant. And we have paroxetine, which is a SSRI or antidepressant drug. I'll give you a second. And you are correct. The answer is D. The SSRI drugs are the first line of medication or treatment choice for PTSD patients.